Well, a very warm welcome, everyone, to this year's Milestones Lecture. I've been instructed not to say very much about John Clarkson, because he's going to talk about himself, I think, during the lecture itself. But I am going to say that, of course, many of you will know John or know of him and know of his work. He is an enormously valued and long-serving member of the fellowship here. He became a fellow here in 1995, having previously been undergraduate and graduate here. So John has been pretty well Trinity Hall man and boy, I think, apart from some years in industry. He is director of the Engineering Design Centre, has been professor in his faculty for 14 years. He told me just before, or he let slip, he absolutely wasn't boasting, he's just been awarded the Misha Blake Medal for International Design Education. So that's a sign of the kind of quality that John represents, and I'm enormously grateful that he's been willing to come this afternoon and talk to you about from firefighting to a systems approach for health and care improvement. After John's spoken, there'll be an opportunity to ask questions, and after that, everyone is very welcome to come down to the Graham Story room for tea and refreshment. So, John, it's over to you.
It's a real pleasure to be here. When asked, I did decline because I couldn't make the date, but the date was moved. So I'm here. So from firefighting to a systems approach, keeps going ahead of me, I'll try again. From firefighting to a systems approach for health and care improvement. So to traverse that journey, what I thought I'd do is to go through what I've been doing in my career. And it only makes sense to me now because I've looked at it from the other end, looking back. So I thought I'd talk about stepping motors. That's exciting. Technology consulting, engineering design, a systems approach, and then health and care improvement. Now, if the logo happens to change in the top corner, that's because it represents where I was when I did these things. So we started out with stepping motors in Trinity Hall. The stepping motor. It's a wonderful beast. It's a digital motor. When you ask it to move, it moves a certain angle. Then you ask it to move again, it moves a bit more. If you keep asking it to move, it rotates. It has a torque speed curve. It has high torque at low speed, low torque at high speed, typical of many motors. It's well known that it has resonance problems at low speed. What was less well known is it had high speed resonances. And nobody really understood why that was happening. But it really compromised the use of those motors in practice. So that's the torque for a stepping motor. That's the equation of motion for the physical system of a stepping motor. It's interesting because it has mechanical terms and it has electrical terms. And if that is to be stable, that particular term in the middle has to be greater than zero. But what's interesting is that one of those terms is mechanical and one is electrical. So I spent 18 months deriving that equation. That was pretty much my PhD, one equation. And it comes from this part here. So then I plotted those two equations. And if you overlay on that where the motor is allowed to operate, and then say, well, what if on this one here, the number goes to a certain negative value? Suddenly you can explain the instability. Now, strange, I knew what I was looking for, but it took 18 months to come up with that equation, with this graph, and that intersection to explain why the motors become unstable. And then I added some software to it, and I could control the instability. So, of course, completely unintelligible. And I could not derive those equations now, but looking back, it was the beginnings of me becoming excited by the interplay between things mechanical, electrical, and then software. And the motor and its performance, which I thought initially was actually about the motor, was much more about the motor and the drive combined, and the system you put it into. And whilst those motors are still not used very much, its successor can be found in things like this, which is the underbelly of a Jaguar electric car. And they got extraordinary motors when put together with the right drives and the right batteries. So those early ideas of systems came from me playing around with what I thought was a component that was actually part of a system. Then I moved from the safety of Trinity Hall into PA Consulting Group down in Melbourne. And one of the finest projects I worked on was on firefighting for the Royal Navy. This was just after the Falklands War. And I keep my knuckles away from the computer here. I keep setting the thing off. So what happens is if you get a hole in a vessel, it goes down and you kill a lot of people. So firefighting on board ship is hugely important. So unlike a building fire where you just try and get people out, on a ship you fight the fire. So the Navy spent huge amounts of effort training firefighters. And this is the old system down in Portsmouth about 25 years ago. 2 units there. The instructors, strangely, are on the outside. The trainees have been sent on the inside. It's railway sleepers, diesel fuel, set alight, left for about 15-20 minutes to heat up. You cannot see your hand in front of your mask. The trainees have to go in and find the fire and put it out. The language is extraordinarily colourful. It doesn't always go right, and if it goes wrong, they have to drag the people out, put the flames out, start again. About an hour and a half later, they can go in and restart the trial. So the challenge for us was to say, well, can we do that with a new system? So a prototype system, one cell, computer-controlled flames, smoke, air, and inside we've got this unit. We've got burners here where we can control the flames. We've got a cool zone where we blast smoking and create that smoke effect in front of the flames. And at the entry, you heat it up to about 300 degrees C with hot air. That's a very hot oven when you open the door. And we send the trainees in to fight the fire. So my job was to build all the control systems that sat behind that. So I wrote all the software to control flames. There were lots of electrical interconnections to make sure we kept everybody safe. And then the plumbing required for the burner. And if my software said, I want flames, the electrical bit has to say everything's safe, and the mechanical bit had to work, and I get flames. So I had to figure out how all those pieces would fit together to keep people safe. We had to design some very smart sensors. So you're putting foam or water onto the flames. How do you know it's there? How do you know which is which? And it can get up to about 1,000 degrees. So some very clever sensing in the area of the fire to pick up what the trainees were doing. I wrote lots of software. That's some of the high-level stuff. I wrote hundreds of pages looking like this. It's called ladder logic for some strange reason, but it all makes the things talk to each other, listen to each other, and do the right things in the right sequence. I had to look at the risk. How do you get propane from a tank to a burner without killing anybody? Now, I was allowed to kill one officer every 10 years. Not a target, but a limit. So we had to figure out, well, what did that mean? So where you see 2 valves alongside each other, that's because the numbers said one wasn't enough. The guardrail at the top right, we put that in because we found out, looking at all the numbers, if somebody fell on top of the fire, you'd be taking out a dead body. If you put the guardrail in place, and you could not use that burner unless the rail was in place, it would be safe enough. So I was responsible for all the risk in automating the process as well. It's all about people. These are actually the officers I worked for. One of them sketched this at the time. And it was the officers who would run the rig to train the trainees. But that prototype they would run for 10 years to figure out how it worked before they scale it up as a national facility. And that's what it looks like in practice. That's a settee fire in a confined space. That's an engine room fire. And that's one of the bigger fires where the smoke is in full force. And it's very hard to see where the flames are. And you take a team of 5 people in there, and they have to choreograph how they fight that fire. And that's what they've been trained to do. And that has now been scaled up. It's used in 3 places throughout the UK, and all naval people on board the vessels are trained every 2 years in firefighting. So what links together Tadcaster, Eddie Stobart, an empty warehouse on the A1, and a rather unhappy-looking Jack D? I've never seen him look happy, but a rather unhappy-looking Jack D. And the simple answer, and the only one I know of, there may be other answers, is that it's beer, in particular John Smith's. And this starts with people, again. It starts with us as consumers changing our habits about 30 years ago. And having drunk mostly beer from the keg, proper keg beer in the pub, increasingly we wanted to drink beer from home. But it didn't taste the same. So the challenge was to make the beer in the can taste like the keg beer. Guinness had done it a few years before. John Smith wanted to do it again. We had to design the widget. And if you don't know what a widget is, that's because you're way too young. The widget was what sat in the can that makes the beer taste like the keg beer. The widget needed a system to put it into the can, and then to take out the air and backfill it with nitrogen. Otherwise the beer goes off. And there was a safety issue. One thing is you have to put liquid nitrogen in the top of the beer before you seal the can. And the other challenge is that too much nitrogen is very, very dangerous. So if you're working with 100% atmosphere of nitrogen around the machinery, if somebody were to reach into the machine, they'd be dead. Now, the safety manuals don't tell you that, but I was responsible for the safety of all the production people. We had to then safeguard the machinery that was bathed in 100% nitrogen. So we have draft beer we're trying to take into a can. We're developing a widget. Stobarts were involved because they were taking the empty cans originally just from the can making to the brew house. But now instead they took them to an empty unit on the A1 and organised a production system to put the widgets in the cans. Then they put them back on the lorry and took them to the brew house. So eventually they come to the brew house and we have to backfill the cans with nitrogen. Nobody at Tadcaster knew that this was going on until the weekend before production started. So it's completely secret. And because people didn't know, nothing leaked out until you saw this fellow on TV advertising beer. And it hit that September sales, having started the project only in January. They paid him at least as much as everybody else got for everything else. But it was so successful that they paid back about 20 million in 7 weeks. And the company went from nearly going bust to being bought out and a huge success. Transformed the beer market. And a lot of it was down to this widget in the middle. And you can see the green fins here. They're flexible. So you could squeeze the widget to get it in the can and sort out that part of the problem. The middle part, a different team were working on to get the size and shape correct. And yet another team were working out how to put the nitrogen into the widget. So whoever came up with that idea in the middle, it was a magical idea that split the whole project out into 3 teams that could work together in complete privacy. Nobody knew what was going on, except that every Friday afternoon, strangely, we got a pallet of these arrive at the office door saying, "Can you try them, please?" Because the only way you can prove whether the beer is good or not is to try it. So by that time, probably a decade or more of training in engineering and practicing engineering, I discovered that engineering really was only 2 questions. How can we do it better? And what could possibly go wrong? And that second question is really the one that defines, I think, as engineers. But I also learnt that it's all about the process. The way in which you go about answering those questions is critical for your success. So at that point I came back to the university. I took on the Engineering Design Centre, and there's a team of about 60 people all together looking at how we improve the design process. So those 2 questions are at the heart of what we're trying to answer. How do we do things better, and what could possibly go wrong? It's the processes behind them. And to give you a couple of healthcare examples that we've been working on, my team have been in and out of Addenbrooke's for probably 15 years now, looking at different challenges and projects. And about 5 years ago, this one came up. So after surgery, and you're recovering, you'll be on painkillers, probably morphine. And the pumps in the background are giving a low dose of morphine. If you want more morphine, but not too much, you press the button. And what we discovered is that 20% of the patients could not press that button. They'd been given it, but they couldn't press it. They couldn't see it, they couldn't find it, they couldn't literally press the button. And the problem is that within the regulatory world of health and care equipment, it's that button has been approved for use. So we couldn't just go in and change the button, but we knew it wasn't working for everybody. So after about 3 or 4 weeks' work, trying to think through what the real challenge was, what the team came up with is a wrapper that goes around the button. In the middle of that is the same button on the same piece of electrical string connected to the same pump. But you can then tack it to the bed or the bedside table or whatever you wanted to. Somebody could hit it with their head, their knee, their foot, and it solved that problem of visibility and people tapping the button. We could always make things better. But the other question is much more interesting. What could possibly go wrong? So about 12 years ago, the Chief Medical Officer came to us in a group at the Royal College of Art and said, well, can you tell us how design can make things safer for patients? And after a lot of work talking to clinicians and engineers, we reported back something strangely called the blood bag report. And it talks about a system-wide design-led approach to tackle patient safety in the UK. So that was our first outing to talk about a systems approach to health and care improvement. And one of the key things that we discovered en route was that it had been said a few times, human beings make mistakes because the systems and processes they work in are poorly designed. So a lot of people were blamed for things going wrong in healthcare, and it was our view that a number of these things were avoidable. And people were put into situations where they would be likely to make mistakes. So that started the challenge of us thinking, well, how do we respond to this? What's our view as engineers as how we respond? We got involved in another project at about the same time. The patient leaves the safety of their home to enter the healthcare system. At the health centre, the patient seeks help to control ongoing pain from arthritis and is referred to the local hospital. It's quite typical. At the outpatient clinic, the patient is assessed and started on weekly doses of methotrexate. At home, the patient manages their medication, taking methotrexate weekly and folic acid daily. The patient's blood is monitored, and the methotrexate dose is varied to control its toxicity. It's normally a cancer drug, so it's highly toxic. What could possibly go wrong? So just over 10 years ago, at the health centre, a locum GP prescribed methotrexate daily, and the error is not corrected despite routine practice checks. At the pharmacy, a locum pharmacist dispenses a daily dose of methotrexate, and the patient dutifully takes the daily dose. The doctor said so. 30 years taking it weekly, they take it daily. A few weeks later, the patient is admitted to the ear, nose and throat ward with symptoms of a severe sore throat, where blood tests failed to detect the problem. In specialist care, blood tests finally show abnormal conditions and a methotrexate overdose is suspected. The patient dies. Horrible, horrible death. The 26th patient to have died from something of that nature over the previous 25 years. So we got engaged then with the National Patient Safety Agency and many of the players in this particular case to say, well, how do we make that whole process safer? And there was a system-wide review, and it led to changes in the tablet shape, prescribing policy, prescribing software, guidance for use, and many other things. There was no one single thing to fix. In fact, all told, I think there were about 18 errors made in that process. And it was a systems challenge to get it all right again. And on the right, you can see there was new material sent out to patients to try and brand methotrexate as something very different. Weekly dose, not daily. Special instructions sent to GPs and prescribers, and even messages coming up on software to say, don't do it this way. This is special, do it different. We are still killing people because there are other problems we hadn't foreseen still coming to light. We also got called in to look at a new unit at Colchester. This is a juvenile mental health secure unit. At this stage, it's just the planner's model. And they said, well, what could possibly go wrong? It's a very beautifully crafted building, it looks absolutely fit for purpose. So we worked with the team who were going to run that facility, and we looked at various pathways of patients and people through the building. And we found there were flashpoints, so potential things that could be really difficult. And they had to redesign parts of the building. We looked at a policy for non-smoking for juveniles. Now that seems absurd now that we would have let juveniles smoke in these facilities. But at the time that was being changed about 8 years ago, the question was, should we adopt a non-smoking policy? So we developed a bunch of personas, people that represented staff and patients, and started to think through the behaviours that would emerge if the children were not allowed to smoke, and what the coping strategies would be. And what would happen if they did go down to the shops? Where would they hide the cigarettes? Was it a fire hazard? All sorts of things. And in the end, they did adopt a non-smoking policy, but lots of planning went into building up to that point. Against the engineers coming in, asking what could possibly go wrong in a structured way. So what could possibly go wrong? Spiegelhalter is another local academic who deals in risk. One of my favourite units is the micro-mort. The 1 in 1 millionth probability of unexpected death, hence micro-mort. So just to put things into perspective, for me, at my stage of life, it's about 10 micro-morts just getting up in the morning. So that's a 10 in 1 millionth chance that I would come to an unexpected death every day. For example, flying then to Vancouver, 4 more micromorts. If you're daft enough to run a marathon, it's another 8 micromorts per run. If you worked in the construction sector, 39 per day. One night in a UK hospital, 75 micromorts. Accepting the fact that it might be 1 million micromorts, i.e. certain death, if you do not spend one night in hospital. And then to compare that to the firefighting, for the unit I was responsible for, 95 micromorts per officer per day. That was my limit. The units they now have distributed around the UK, from what they've learned from the prototype, the limit is 1/2 of a micromort per trainee per day. That is extraordinary for people playing with real flames to learn how to fight fires. But that's the levels of safety you can achieve by asking what could possibly go wrong and designing out all of those possibilities that could be dangerous. But these questions come together. You could imagine 10 years ago that truck was driving around with the haystack straight-sided. And somebody said, well, what if we put an extra half bale on the second layer? And it sort of works. And the next year, well, what if we put an extra half bale on the third layer? And so it goes on. You get this creeping acceptance. You think you're making it better without realising what could possibly go wrong. Now, for those that come from the healthcare community, that's my mid-staff's truck. That creeping acceptance of things that are just plain wrong. So at that point, we've been working in risk and working in systems and design for probably 10 years. And the Royal Academy of Engineering asked me to chair a working group to look at a systems approach to health and care improvement, with the Royal College of Physicians and the Academy of Medical Sciences working with us. And the challenge was to work with the health and care professions to explore how engineers can add to current understanding and practice of systems engineering in quality improvement and healthcare design. And this had come about because of many of these safety issues before, but for about 20 years, almost all the key reports that have come out of health and care about things that have gone wrong, somewhere in the appendix they've said maybe they should take a systems approach. But nobody sat back and actually defined what that looked like for people to know what they should be doing, what they were missing. So we ran a series of 4 workshops with patient leaders, clinicians, physicians and pharmacists, systems engineers and improvement professionals. Probably 2/3 clinicians and 1/3 engineers. We started from an engineering definition that systems at work do not just happen, they have to be planned, designed and built. That's the engineer's view. So we then looked at systems engineering as a discipline. Now that is an extraordinary diagram, probably 30 years in the making. Really captures all the nuances that are important about taking a systems approach. But it's like my equations, it's utterly unintelligible unless you've been steeped in the background of systems engineering. So what we then said, well look, a systems approach, we've got to come at it in a much simpler way. The systems engineering view is far too complicated. So we took that view, and these words you've seen seeded in the slides before, that a systems approach is about systems, it's about design, it's about risk, and it's about people. Those bring different perspectives to a systems approach. So we ran a workshop in each one of those areas, trying to unpack what that perspective looked like, what the clinical side thought it was, and what we as engineers thought it was, and what we thought was important. So what I'm going to show you now is a few of the slides and questions that came out of those workshops for each one of those areas. So for the systems approach, it's often about a system of systems, and this picture worked really well, that the human body could be thought of as a system of systems. The waterproofing system, the plumbing system, digestive system, and so on. And the emergent behaviour is far greater than the sum of the parts. But if one part isn't working or there's local trauma to a part of the body, it can severely compromise the operation of the whole. So engineers and clinicians have that common understanding of systems of systems. To take a different view, the patient comes to the GP to seek help, and maybe the answer is a prescription. And there's probably a computer system or formularies behind the scenes to inform what should go on that document. You go to the pharmacist and they have their own delivery and dispensing system to provide the right medication in the right dose and the right form for the patient. Then the patient has their own system. And this is typical for folk over about 65. And we conspire to make everything look the same with the pharmacy label. And yet you've got to take different amounts of different things at different times in different doses. If any one part of that system fails in some way, we probably end up delivering the wrong amount of the wrong thing to the patient at the wrong time. The questions that came out of that were, well, who are the stakeholders? Who are the people who have an interest in that system? What are the elements? What are the parts of the system? And how does it perform when you put those things together? That was the systems perspective that we came up with. And we summarised that as understand, organise, and integrate. Then there's design. And we often started with this double diamond model because people are very good at coming to you with a problem or often a solution. Clinicians often come to us with solutions. This is what I want you to make for me. So you say, well, what's the problem? And beyond that, what this model pushes you to do, so do you really understand the need that sits behind the problem? And we should probably spend as much time thinking about the need and how it translates into a problem as we should thinking about finding the best solution for that particular problem. So that's an interesting challenge when you think about design, that, say, most of us, engineers included, start in the middle, but we have to be pushed to go back to the left-hand side. What's the need? Design might be about something very, very simple. Blood pressure measurement, something that equipment's been around for decades. It works. It might be the design of a piece of kit as part of a suite of equipment within the complex operations of the operating theatre. That brings particular challenges. It might be a designing the experience. That's a GE 750 scanner. But if the child is told they need a scan, they're told they need to come on an undersea adventure. When they turn up to the hospital, everybody is in costume, and they act out the roles to take them on an undersea adventure. And success is you get a good scan image, and the child says, "Can I come back tomorrow? I want to do that again." So it may not just be about the equipment. That's a defibrillator for use by the general public. So design of that says not only should it work perfectly first time, but you've got to design the information content very carefully so that a complete novice can pick it up and understand how to use it and make it work right first time. So understanding the needs behind things can be quite an interesting part of the challenge. So what are the needs? How can the needs be met? And how well are the needs met? And we use the term explore, create, evaluate to describe that process of design. Risk. And this was the only time we put an engineering-like graph up in front of the clinicians. So if you want a particular outcome, most of the time, the outcome you get is what you want and it's normal. But risk is as much about saying, well, how do we understand the exceptional and make the normal look more like the exceptional, as well as it is trying to avoid the accidents. So can we shift that whole curve to the right-hand side? So we've studied at length central line insertion in the local hospital. There's a guide wire here, which is part of the process for getting the tube into the patient. And we know that at a particular point of the cycle of insertion, if you interrupt the person putting the line in, they may forget whether the wire is inside or outside of the patient. It sounds ludicrous, but it's entirely possible. And using engineering techniques, you can predict at somewhere like Addenbrooke's, that will happen once a year. And it does happen about once a year. And half the anaesthetists say it would never happen to me, half understand the caution that's required. And there are design solutions maybe to work out how to do that better. But the engineer's view is that will happen at a certain rate. We don't generally kill people, but it is really inconvenient to have to open somebody up again to pull a piece of wire out. Infusion pumps, prolific in their use in hospitals. There's a team at Swansea University who look at the design of the interaction of the pump with the operator. Most of those pumps are deeply flawed in the way they operate. So say you want to type in 15.7, and you tap in 15.5. Oh, delete the 5 and 7. You've now actually put in 157, because the person designing the pump has made assumptions about how you will think when you use the pump. Every pump is different in the assumptions made. And there's many cases emerging of nurses being prosecuted for making mistakes when it's actually the bad design of the pump. So we have to understand risk and the systems of risk in a much better way. If you take just an interesting busy ward scene, change in staff, what could possibly go wrong? So these questions, the way you tackle risk, is as much about how people work with each other as it is with people and equipment. And yet you need to take account of the fact that people just make mistakes. That's Hamilton, Malaysia, 2013. He's just swapped from McLaren to drive for Mercedes. His very first pit stop after that change of team comes storming into the pit, and he stops at the McLaren crew, where he's always stopped. And they do nothing, they just wave him on. So people make mistakes, and how do we make the systems around them resilient to the mistakes that they might make? So from a risk point of view, you do need to know what is going on, what could go wrong, and how can we make it better? So there's already some overlap there with some of the other perspectives. Examine, assess, improve. Then there's the people perspective, and part of that's about diversity, both in the patient population and in the population serving the patients. So someone who's got arthritis, who is struggling to open jam jars, why do we give them child-resistant containers for their methotrexate? Well, they have to then develop coping strategies to get their medication, which can increase the danger. That's the same medication in the morning when you haven't put your glasses on yet. That there is methotrexate. That's the weekly one, which if you take daily, you kill yourself horribly. We've conspired to make them look the same within the patient's own world, where we severely compromise their ability to keep themselves safe. Now, in that case, they have taped 2 bottles back to back. So by touch, they could find the methotrexate. But one of them is 10 milligram, one of them is 2.5 milligram. They look identical in size, shape, and colour. And if you take the 10s instead of the 2.5s, you know what's going to happen. But what about the language we use in healthcare? Is it simple, clear, consistent, all through our lives, so that we understand it? I'm not sure. I suspect not. And another perspective on the people side is to say, well, if we come up with some improvements on one particular ward with one particular team, should we expect that to work on a different ward in a different hospital? So from a people point of view, who will use the system? Where is the system? What affects the system? And we've put that down as identify, locate, and situate. So we have 4 perspectives on a systems approach. The systems, the design, and the risk, there's an interplay between them. It almost doesn't matter which one you start on, you tend to end up looking at all 3. And the people side permeates everything. So this is what emerged out of the workshops. We have a set of 12 questions that are starting to define what a systems approach looks like. But there's also some project-type questions. Why are we doing this? What is the purpose? Who should be involved? What does good look like? So I think one of my favourite questions. What does good look like? And what should we do next? Now, if we mash all those questions together, strangely, we end up with a spiral. I presented about 20 different ways of looking at this, but the spiral infers that there's some iteration required. You've got to keep answering these questions. There is a natural order, and if you keep asking them enough times, you will get to the system is the one you want, that is safe, that's the right system. But it's all a bit academic and abstract, and on its own, it's not really helpful. So we went back a step and said, well, what does the improvement process look like? You want to go from current performance to something measurably better. There's some sort of trigger that starts you on that route. You've got to understand what you're doing at the moment, how well you perform. Build a case for being allowed to do something different. Design the intervention, plan its delivery and its acceptance, and how you're going to sustain it. So that's a very simple but natural improvement process. And our view is that those questions that embody a systems approach could be wrapped around that process. And that's what came out of all that work with the Academy. So that there's a report called Engineering Better Care, which gets you to that point, saying, well, that is what a systems approach is. And some other observations we also got from the workshops. Engineers think about people. That surprised the clinicians. But most of what engineers do when they're designing systems is thinking about people. Iteration before implementation. Engineers like to iterate before they put the product on the market. We do all the thinking and testing before we let the aeroplane fly, not afterwards. In healthcare, let's try something and see if it works, is the dominant way of doing improvement. Design is an exploratory process. How many things can you think of that might be the answer so you can pick the one that's best or the combination that's best? Risk management is a proactive process. So we're asking what could possibly go wrong, as well as looking back and saying what actually went wrong. But both of those together are very, very powerful. From your experience, you can double guess many of the things that you've never seen but could go wrong. You may have to design some of those out. Thinking changes practice, and process helps. And that was more a reflection on us coming up with a set of questions. We wanted to challenge the way people were thinking, hoping it would lead to a change in practice. The challenge is that people actually want a process. They want to be told what to do. So we have to think, well, how do we move beyond that? And common sense is not common. We were told time after time, there's nothing new here at all. Not rocket science, it's common sense. And we know there are many islands of real excellence in terms of healthcare delivery and improvement. But this sort of common sense is not common, which is an interesting part of the challenge. So what happens next? So we've delivered the report to the Academy, to GPs, about a year and a half ago. So how do we translate what is a way of thinking into a way of doing? So we're carrying on working with the academies and now with the Royal College of Anaesthetists. They're very proactive in ongoing training of their cohort. So what are we trying to do? We're trying to develop a toolkit that fundamentally answers those two questions. It's about the patient surrounded by people, surrounded by equipment. It's a systems of systems view we're trying to understand that we need to deliver. What is the purpose of the system? Where is the system? Who will use the system? And what does good look like? Maybe some of the key questions we want people to be able to answer or be facilitated to answer with the toolkit. We've come back to that same process model and said that's fundamentally what we need to be able to do. But how do we help people do that more than just supply them a set of questions? And there are more questions. Where we're starting, well, what do we do now? How well do we perform? What would be better? What should we measure? You need to be able to answer these questions before you even know there's any improvement that you can make. What should we do next? Well, yeah, what's the plan? People love to have a plan. But none of that makes any sense unless you can answer what is the case for change. You can have a wonderful idea, and it could be really good for patients, but if you cannot make that case to the people going to give you the time or pay for you to do the development, you will make no progress. And that's the sad reality of doing things in health and care, that the question at the bottom is probably the most important. But to get to that, you need to answer some of the other questions. So to unpack that, we've said, well, what are the simple things you can do? You may have a scoping meeting with the top team just to say, look, is there something here we should be looking at? Is it even a purpose to come together for the second meeting? Is there something that we can identify that we could improve? Then you go away and look at your hospital data. You walk around, you try and understand what's going on. You try and figure out, is there really a need here that we can respond to? And even very early on, you go through a creative phase with the team and say, can we come up with solutions? Now, it may be way too early to do that, but unless you do that, you can't then think what the case might be and how you know you've got there. What do you need to measure to know that you've had success? And only then can you plan some way forward. And then you go back and do all these things again. You go back and look more carefully at the need. You're much more rigorous at looking at the solutions and the risk and so on. So we've been trying to develop a set of cards. It's a small pack of cards that try and identify some of the things that might be important for health and care professionals as a part of a process, part of a toolkit. Cards that might explain what a systems approach is from a physical point of view or a human point of view. There's cards in there that describe the existing healthcare improvement models. PDSA, the IHO model of healthcare improvement, is the mantra of healthcare improvement in the Western world. It's downright dangerous, but it is what people know. And if used well, you might get away with it. If used without thought, it is dangerous. So how do you reconcile that, which is what people know and what they're going to do, with the engineering questions? That's part of our challenge. We describe particular activities. How do you draw the boundary of the system? Because you're going to need to do that. And the card is a prompt to say, well, how you might do it. How would you identify the patient pathways? Capture the needs, and many other particular activities that could be fundamental to do the improvement. We describe service users. So we go through the life course and have these personas that are stereotypical patients, just to prompt you to think, well, what is the range of people you're dealing with? Jamie's mum, or an older gentleman. And you might, for a particular area of improvement, think, well, who are the personas that would help me understand what I'm trying to do in my area? There may then be many other stakeholders, the consultant, what are their needs? Or the community worker, or Fred. And Fred's important when somebody, for example, goes into palliative care, or is rushed into hospital. What about Fred? Fred's really important to understand. How do you deal with Fred when you're trying to do everything else as well? One of the stakeholders. And then we have case studies. This is a case study, for example, of care for the elderly in Sweden. It's a classic case study of people taking a systems approach and coming up with something that really did work for the older people and the community, and then the methotrexate. So we're up to about 200 cards at the moment, prompting different thinking, different ways of doing. But again, on its own, it's not enough. It's just a distraction, it's a bit of fun, something I do drawing things late at night. So we've got to try and put it back into a toolkit. The cards are ways of engaging with people, prompting what they might do. Guidance would explain, well, why do we have these different sets of cards? What are the different colours for? What do they mean? And most importantly, which do I use when? How do I construct a process out of what I think I want to do and where I want to get to? And keep reminding people of process. We have posters, worksheets you can put on the wall to help facilitate and guide people through this improvement process. Now, the biggest challenge here is, who's the user? The user is the user of the toolbox. Now, is that an engineer who goes into a trust to run alongside the clinicians? Or is it the improvement specialist in the trust? Or is it the consultant or the nurse? And that's one of the biggest challenges for us as a team moving forward, is to reconcile, well, is it the engineer or the clinician? Who is it that is going to own this toolkit and therefore be able to deliver better care? And there are many, many answers to that question, which makes it quite challenging knowing quite how to move forward. But what are we doing? So if we want to deliver engineering better care, we are addressing all of these areas of practice right now, mainly with engineers, but with one or two clinicians in there running these projects in practice to see transformation take place. We're also doing a lot of research. Half of my research team outside my office now are clinicians in the engineering department trying to get PhDs or master's degrees in engineering, all about a systems approach to healthcare improvement. And we're looking at global health, trauma care in Myanmar, for example. We're looking at community care. We're looking at particular issues of practice in the hospital trust itself. And at the same time, we're researching, how do you do health systems visualization? How do you draw the pictures of the system so you know what it is? And you can get an anchor on it to say, well, this is what we're playing with, this is what we're trying to improve. How do you do this prospective risk assessment? So this interplay between the practice and the research is crucial, as is the mix between the clinicians and the engineers, and we're trying to take it into training. So we are developing very specific toolkits. We're developing a palliative care toolkit for Marie Curie to be something that can be used to design palliative care anywhere in the UK, and one for global health, translating the language of what I presented here into something that would be appropriate in global health, with the expectation that will be the way that people go about global health improvement. They will take a systems approach to designing and developing changes. And we've also started teaching clinical students about a systems approach. And it's fair to say that 60% think it's wonderful and 40% think it's an utter and total waste of time. So that's an interesting challenge, and I'm not that surprised by that. But maybe success will be measured with a different balance later down the road, that as we train our clinicians, they not only learn how to be exceptional doctors, but they learn how to take in their stride this ability to say, well, how do we do it better, and what could possibly go wrong? So systems at work do not just happen. They have to be planned, designed, and built. Thank you.
John, thank you very much indeed for a wonderfully stimulating lecture. There must be questions, so we've got some time for questions. So, yes, gentlemen in front.
I love the system that you've developed, but at one point you said that the existing model was positively dangerous, and I wondered if you could just say very briefly what are the main risks in the way that we're doing it now?
PDSA, Plan, Do, Study, Act. Now, critically, it comes down to the quality of the planning. So it was designed as a way of making small local changes. So you plan, you think about what you want to do, you do it, you see if it works well, if not, you've altered a bit, and you keep going around the cycle. It's not designed really for major change. So to give you one example, I had a long argument with a Welsh consultant about this. She thought she was doing wonderfully well with PDSA. So on her ward, she was looking at the patient notes and trying to figure out who most used the notes. And it was the consultant and the nurse. So they separated out the two key sets of notes that those two individuals will want, and they coloured one green and one red. So for their local ward, perfect solution. Everybody knew where to go for the information they wanted. So I then said to her, well, what if the ward next door goes about the same process, they don't talk to you, they come to the same answer, but the colours are the other way around. Then you get a bank nurse who spent 2 months working on one ward, and overnight goes across to work on the other ward. What could possibly go wrong? And it's if used really well with a deep understanding of what improvement is really all about, you can use it as a base start point. But fundamentally, I think it's dangerous.
Thank you. Yeah.
Hi. I was just wondering if you had any quick sort of tips for how do you run that mental simulation of what could go wrong? I mean, you can come up with ideas, but how do you feel like you've thoroughly rinsed the problem of coming up with every single thing that could go wrong?
So one of the ways of doing that is literally drawing the picture of the patient pathway and how it intersects with the different clinical teams. And you make an assumption that what you know is correct. And then you say, well, what happens if this bit breaks? What happens if the communication fails here, or that piece of equipment doesn't work? What would happen? Could it be dangerous? So you try and be systematic in addressing all the different things that might fail. And to add to that, you simply say to people, look, tell me what did go wrong, and from your own experience, what are the things that would worry you, that might go wrong? But the engineering methods allow you to be much more systematic, and you have a picture of the system, and you go through every single part of it, poking and prodding it, trying to push it away from its normal position, say, well, what would happen? And often you find that what you thought was good is fundamentally flawed in the first place.
Thank you. Yep. Simon.
Thanks. John, you described a kind of system for embedding systems engineering. And I wonder what the measure of success should be, because you said the measure of success is that more people think like me. And I'm not sure that's acceptable.
I would be happy if everybody who serves the patient is asking those two questions. How could I make it better? But counterbalancing it with what could possibly go wrong. Now, if that was as far as I've got, I'd be happy. Now, beyond that, you can say, well, what are the tools and techniques you can embed within organisations that enable them to do that to a deeper level consistently? Now, that I would like to see. I'd like to see each hospital trust, each community trust being able to be more rigorous in their development of good or better systems. But at a local individual level, think like me, yeah, just that counterbalance of the two questions.
Okay, yeah. Hi. Early on, you mentioned the regulatory problem with the button.
Yeah.
It strikes me that regulation, the current regulatory setup, is going to be a problem for your systems approach because it's trying to pinpoint liability and responsibility.
It's interesting, when you're not dealing with technology, you have a lot more freedom as to what you can change. So if something has been approved, or it's got a CE mark on it, it has been approved as is, and it's much harder to change. If you're changing the way people work, you've got a lot more freedom. And interestingly, surgeons take great liberties in terms of what they do that's different for every patient, how they learn how to do things better. And it's just as well that they do. But they don't have to go to get regulatory approval every single time they do something different. So I think when you look at the systems and the process, you have a lot more freedom than you think. When it comes to technology, we can actually design and deploy equipment on the Addenbrooke site. We don't have to go to any regulatory body to do that, because we're not going to put it on the market. But as soon as you want to make it publicly available, there's a whole different game that you've got to go through, and quite rightly so.
Hello. You talked about nurses being prosecuted when the flow devices, possibly it was a problem with the device itself. Yeah. And there was a case in the papers earlier about a doctor being struck off. But how generally do you think the legal process and culpability plays with the sorts of improvements you want to see?
I don't think it's a problem for what we're trying to do. I think there's equipment out there that has been designed by engineers to be used in complex environments, and they're simply not fit for purpose. So some of the early infusion pumps, the measurement was in inches per hour. Now that's for a volumetric measure of drug into the body. So immediately you're demanding that the nurse has to make a calculation to get the dose right. Well, that's absurd. And the fact that all these pumps are slightly different in the assumptions they make and how they behave is inciting people to make mistakes. So I think we must get the equipment right, but I don't think it gets in the way of us trying to make improvements, as long as we do it in the right way, with the right level of rigour.
There's one at the front here first, and then...
You'd highlighted the problem of the medicines a couple of times. I was just curious as to what the solutions there were.
The one with methotrexate is really interesting, because I think that's a particular anomaly. There's only 6 medications in the UK that you prescribe weekly. Everything else is daily. So it's a very difficult one to manage. And I just think particular vigilance with the individual patients is what's required. There are other cases where we simply get it wrong, and I'd love to see the pharmacy label changed. I think they've done a lot of work on redesigning packaging of medication to make sure the drug name is identifiable, distinguishable, and the dose is easy to see. And some people use colour to do that, others other ways of doing it. And then we put the pharmacy label over the top. So there are certain things like that we could do a lot better, and there are other parts in the world where they are much more cognizant of these particular challenges and much more patient-centric in how they're trying to help the patient take the right dose at the right time. I think there's a lot more work to be done, to be frank. I don't think we're anywhere near where we should be in safeguarding patients with medication.
Hello, I'm a regular patient at one of the major London hospitals and have a huge personal interest in the safe delivery of drugs. Listening to this, I've drawn my own plan of all the potential pitfalls and things that could definitely go wrong. If I actually sort of made some notes of my own and came up with a proposal, where would I take it if I want some action to happen?
Bring it to us to start with. We'll look at it. And we've been into patients' houses, particularly taking methotrexate, and we've seen how they put their own charts together to help them manage their own medications. Now, at one level, that's an extraordinary, very good thing, because they're taking control, making sure they understand what's going on, and managing their own medication safely. But are we pushing them into that situation because of our lack of care in other areas? That's an interesting challenge.
Are you doing any work in general practice?
I have a GP sat outside my office at the moment, and there's a lot more we could do, but what he's particularly looking at is the communication from the emergency physician back into general practice. So somebody goes into A&E, they're seen to and they're discharged, and there's a note made that's sent back to the practice. And his own experience is that the quality of information in that note leaves a lot to be desired. But he works in A&E a lot as well, so what he's understanding is that how you write those notes, you learn from your predecessors, who were all emergency physicians. So his job is to figure out, well, what does the GP actually need, And can that be communicated back into a set of prompts to the emergency physician to make sure what they write satisfies that need? And we're also working in palliative care, so we're looking at anticipatory prescribing, for example, which is a particularly challenging and dangerous area.
Yes.
Yeah.
So within general practice, I'm a GP. Within general practice, each practice is different, and we all evolve our own ways of doing things. And it just strikes me that it would be beneficial for general practice if we all did things the best way, as you were saying. And on one note, with the methotrexate, they've stopped us prescribing the 10 milligram methotrexate tablets now, and we get pop-ups everywhere about methotrexate.
But that used to be region by region. So if you come from a region where you have the 10s to a region that doesn't, and you're told that everything is 2.5, we nearly killed another patient because of that change in policy. So one of the things for us is an interesting challenge is to say, well, can we think about what that toolkit might look like for GP practices that would give some benefit for some of the ways we're thinking here, but described in a way that could be enacted within the confines of the GP practice?
One more, I think, last question at the front.
Thanks. This is not a criticism, but just to invite you to comment on it. I don't think at any stage you used the word cost.
So the reason I accentuate that question about the case hides the fact it's actually almost always about cost. If you can't make a case for change, and we've found this several times up in the local hospital, we've had clinicians come to us with challenges. We've worked through with them what a potential solution would look like, which would be a huge benefit to patients, but we could not make the case with the clinicians or without them. We couldn't make a case to be allowed to take it further. So that word case hides cost. Yeah.
Good. Thank you very much, John. Thank you very much indeed. I think we should show our appreciation and then tea downstairs. Thank you.